And I want to thank our folks from Mental Health and Addiction Services and Medicaid. We've got Angie Bergerfer, Doug Day. We also have Sarah Zielinski and Cicely Hill. They've been going around doing these trainings and they're doing a really great job.
So just to give you a little bit of background in what you're going to be seeing today, this is, even though it's 100 slides, I would still consider it to be kind of a high-level overview and summary of work that has been going on for the past 18 months to 2 years across the Department of Mental Health, the Department of Mental Health and Addiction Services, the Department of Medicaid, in conjunction with the Office of Health Transformation. So this is a joint effort at the state level, as well as a collaborative effort with a variety of stakeholders. So boards are involved, providers are involved, advocacy groups are involved, individual consumers have participated. We've got consultation from Deloitte and Mercer, who is serving as our actuary and providing consultant work related to policy development. So just wanted you to know that the work you're seeing today isn't just department work, it really is reflective of everybody's input across the behavioral health system. So the first thing that we wanted to make sure that everybody was aware of is the Behavioral Health Redesign website. So it's bh.medicaid.ohio.gov, and this is where we post all of the information related to the behavioral health redesign. So you will see presentations from all of the stakeholder work groups. You will see updated rate and coding charts. You can use this website to sign up for the MIDSPITS and the BH Redesign newsletter. So really any of the information that is being shared through any of the stakeholder groups, those are all made available on this website. So I would definitely encourage you to visit that website often and make sure that you're signed up for the newsletter and the MIDSPITS, because we are pushing information and doing updates on a weekly basis, if not bi-weekly. So there's tons of information that stays current out on that website. In terms of the agenda for today, we've got quite a bit of material that we want to share with folks today. We want to take a few minutes to talk to you about the priorities for the redesign, what the vision is, what we expect to achieve, what the outcomes of redesign are to be. We want to also be able to give you very specific policy updates. So we are going to be covering several different policy areas and providing updates. We want to talk specifically about evidence-based practices, assertive community treatment, intensive home-based services, SUD residential. So we've got a whole section specific to evidence-based practices, as well as substance use disorder benefits. We want to walk you through the construct of the state plan amendment, the services, the ASAM levels. So you'll be getting a lot of information specific to that, as well as some of the changes related to farm management and med-somatic that are effective January 1 of the upcoming year. We're moving forward with coordination of benefits that will also occur in January, so we'll be spending some time talking about what Medicaid is doing in relation to Medicare and other third-party payers, as well as requirements that may be changing or that will be changing related to information we need on claims for Medicaid purposes, specifically a rendering provider number. We want to share the draft budget models with you all, as well as the draft code chart and the rates that have been proposed to date, and talk about the proposed direction we want to go with managed care. Then after the lunch break, we're going to be getting into the new Specialized Recovery Services program and talk about how that relates to managed care, both my care and managed care generally speaking. So that is the agenda for the day. So this slide summarizes the outcomes and vision. We do get questions about, okay, what is the plan behind this? What are we trying to achieve? What is the vision? So we have several bullets listed to be able to describe to folks what we hope to achieve through the redesign. The first is that we want all providers to be practicing, all individual clinicians to be operating at the top of their scopes of practice. And you'll see that theme throughout the course of the morning and moving in that direction, that we are wanting practitioners to be providing services within their scope. And that's really the new paradigm shift from where we are today. We also want to make sure that we are lining up our coding structure and following national correct coding. So that is something that we will be talking about quite a bit this morning as well. We really are feeling that that is going to help integrate behavioral health and physical health care and line the behavioral health system up with how the rest of health care codes and bills for services. So we also want to talk or move into providing some additional services in the continuum of care, specifically for those that have high intensity needs. We get questions all the time, are we trying to build a system that is specific to those with most in need? We are absolutely wanting to make sure that we've got a continuum that addresses and provides services for those most in need. But we also want to make sure that we've got services and supports for everyone that would need services across the continuum, and want to make sure that we do that in a way that is sustainable within the budget. We want to be able to move forward with evidence or episode-based payment and purchasing value rather than volume. So as you think about all the changes that we're talking about in terms of coding, that really helps us then be able to understand services that are being provided and kind of help us move in and gather data related to utilization so that we can start looking at different ways of purchasing services in the future. We want to ensure that we have coordinated benefits across payers and do so in a way that actually is the most beneficial to individuals receiving services. And then the last bullet again is related to the coding of Medicaid behavioral health services and making sure that we are lined up with the rest of healthcare and consistent with how they're doing their coding as well. So again, those are the types of outcomes and the vision that we hope to achieve when we are done with the redesign process. In order to organize the work, we've kind of broken things down into 4 buckets, if you will, with some specific timelines for each. So the first bucket related to the redesign is the 1915I program for adults with serious and persistent mental illness. So this project actually aligns with the disability determination process that Medicaid is going through, making adjustments to that process, and you'll hear more about that later in the presentation. But kind of in a nutshell, to give you a frame of reference, there will no longer be an option for folks to be able to spend down to receive Medicaid. They will automatically be enrolled through a singular process if they meet SSI eligibility. So we'll get into more detail on that, but folks won't be required to spend down. So we know that there are folks that through that process could be at risk of losing Medicaid eligibility, and we want to make sure that we have a backstop for those that need high-intensity care coordination. We want to make sure that their eligibility is maintained. So we are bringing up this the Specialized Recovery Services program for those specifically that could be at risk that need those high-intensity services, and those services aren't necessarily available through Medicare or the exchange, which would be an alternative option for folks if they don't meet eligibility criteria moving forward. So with that new program, we anticipate roughly 4,000 to 6,000 folks that could be eligible, and it's based on specific financial and clinical criteria, but they will have access not only to the services that are available through the Medicaid program generally speaking with the medical card, but they will also have access to 3 additional services. The first would be recovery management to make sure that their services are being managed. They also will have access to individualized placement and supported employment, which is an evidence-based practice related to supported employment, specifically for those with SPMI. And folks will also have access to peer recovery support. So we are very, very excited about that new program starting this coming July. The second major area of the redesign is what we're calling rebuilding behavioral health system capacity. So in that area of work, that's where we have included all of our coding and bringing up the additional services, taking a look at some of the current services like health homes and CPST, and kind of sorting through what's being provided and purchased through those services, as well as making sure that we've got a full continuum of care available and that these services are, again, sustainable. So this is where we have a bunch of our coding, our rate setting, bringing up the continuing, adding the new services, things like that. And that work, the first wave of that will be rolled out this coming January, and we'll give you more detail on the timeline here in a few minutes. The third bucket is related to managed care and the carving in of the behavioral health services into managed care, and that is targeted for January of 2018. And then the fourth bucket is related to payment innovation, and that's where we would be looking at new reimbursement methodologies that focus on value. An approach to that could be reimbursement based on an episode of care rather than on an individualized service basis. So those are the four areas of redesign, and we would be looking at phase 4 of payment innovation to come after or closely aligned with the transition into managed care. So in terms of the process that we've been using, we have had weekly, bi-weekly, monthly, daily meetings to be able to work through all of the details and the nuances related to policy topics, rate setting, you name it, anything related to redesign. This is a major focus of what we are doing every day. So we have been doing this process with stakeholders, like I said, for many, many months. We have been using a continuous feedback loop. So we have our meetings, we get stakeholders together, we work through the issues, we get suggestions, feedback, we go back and do our homework, and we bring back another model based on recommendations. So again, this has been an ongoing back and forth process that we've been using for several months. We've also been using surveys based on the topic to be able to gather information more broadly. So this slide summarizes some of the issues that we have heard throughout the course of several months. And just to give you a sense of kind of what we're hearing and kind of the disposition. So I'm sure nobody is surprised that we have heard that rates are too low. So if you've been tracking, and we'll get into this in more detail later, but we have had a continuous feedback loop working through those rates and assumptions and making adjustments based on what we're hearing from all of you out in the system. We have heard that we need clarification on the rate table that Doug will be walking through. So we have expanded that quite a bit, and on a weekly basis, we're adding more detail to that coding chart. Folks want specific clarification on coverage and policy issues, all the way from how crisis services are delivered and coded and paid for to how do we use school psychologists. We need additional clarification on the evidence-based practices. We really need to take a look at partial and consider the addition of day treatment. So we've had focus groups in many of those areas that we'll report out today. But I think one of the biggest things we heard is the aggressive nature of the timeline. So, in hearing that several months ago, we kind of went back to the drawing board and reworked and revised our timeline based on stakeholder feedback. So the next slide gives you a sense of what that timeline is. And the thing to point out is that we've adjusted major milestones related to the timeline, but the finish line and the finish date for some of these projects has not changed. So I will walk you through that very quickly. So on July 1st of this year, and I already mentioned, we are moving forward with implementation of the Specialized Recovery Services Program for a group of folks. So we are on target for that program to be kicked off. We will be moving forward this January with a system transition related to coding of farm management and med-somatic into evaluation and management codes. And so just a little bit of history on that particular change. Back in, I think, 2013, the AMA eliminated the use of the 90862 and replaced that and required providers to use evaluation and management codes. So at that time, we switched out the 90862, which was eliminated, with the 90863 as a stopgap measure. So at this point, we've known that we have needed to address that issue over the past few years. So we will be transitioning this January from the 90863 for farm management and the H0016 for med-somatic services into the evaluation and management codes, and we'll give you more detail on that. But all providers will be required to make that transition January of 2017. At that point, providers also would have an option to moving to the new code set, which has the expanded list that's in your coding chart. So that would be the first time that providers are able to move into the expanded code set, if you will. Providers would also have an opportunity to pick up the larger code set on April 1st, but everybody has to be transitioned to the new code set for July 1st of 2017. So the July 2017 date has not slipped, but what we've done is modified and moved the January date, quite frankly, for folks to be able to, for the first time, to move into that new code set and require folks to be compliant and moved into the new evaluation and management codes. So also for January, Medicaid will be enforcing the Medicare edits and requiring that we have rendering provider information on the Medicaid claims. So that will also be effective and implemented this coming January as well. The next slide is also related to kind of the timing of what I just described, but also wanted to give you a little bit more context and a few more milestones that we are working on related to redesign. So the first row across the top is related to the Specialized Recovery Services Program and when we're going to be doing trainings for the recovery managers and when eligibility will be occurring and kind of how folks can work with their individuals that could be eligible. So we're going to be giving you a bunch of information after the break on how that needs to work, but wanted to give you kind of a slide that has everything kind of in context. We're also working on state plan amendments to support all of the changes, as well as Medicaid rules and Ohio MHAS certification rules and manuals and everything that providers and individuals receiving services would need to know about what the benefit is, what the coverages are, what limitations may be, how you bill for services. So that information is being developed as we speak. We're also working behind the scenes on the BITS build and the business requirements and are hoping to get those finalized in the next several weeks because we know that is the information all of you need to be able to make any adjustments to your internal systems or any sort of workflow changes that might need to occur as a result of the redesign. So we absolutely understand the important nature of getting that information into your hands so that you can move forward with what you need to do to be prepared for any of the changes. We're also doing a variety of different types of trainings to be able to engage folks and also help prepare the system. So we did hold a series of trainings related to coding for the evaluation and management. Did anybody have an opportunity to attend the trainings that we held with Diane Zucker? Okay, good. So that was very specific to coding changes in January for evaluation and management. We are hoping to be able to provide that training later in the summer and in the fall as we get closer to that January implementation date. So we will certainly keep folks posted on that, and if additional opportunities are available for that particular change. We also want to be looking at training dates once the manuals are complete, to be able to train on the specific manuals, which will have much more detail around the coverage and the billing procedures that, we might not have the detail today, but know that we need to do additional training for folks in the future. We have a series of these types of forums that we are happy to, continue on as we have additional information that we want to share with folks, and then have training specific to some of the targeted areas. ASAM training, evidence-based practice training, assertive community treatment, ihbt. So, we'd also be interested in your feedback in terms of what additional training might be helpful as we move forward, knowing that the first time all of this needs to be in place is January, so we really want to have everybody as prepared as possible. So now we want to start diving into the policy details and some of the changes that will be occurring. So we framed this as targeted topics and our smaller work group sessions that we've been having over the last several months. So we've had targeted work groups related to the budget and the rate assumptions, where we had folks get in a room and work with our actuary and understand all of the assumptions that were made, provide feedback to us. Sometimes we had those assumptions, they were off base, and we needed to go back and we needed to adjust the assumptions and rerun the rates. And so we have a group of folks that were working through that with us. We have a specific group that's focused on kids issues. We've had a group focused on SUD residential, opioid treatment programs, crisis services, how we walk through the new therapeutic behavioral services and psychosocial rehab. And so, I think my point here is that we are absolutely, seeking feedback, wanting this to be collaborative across folks in the system. So what you're going to be seeing over the next several slides kind of as a result of that type of work that we've been doing. So in order to be able to have everything cross the finish line with our target dates, we had to take a step back a couple months ago and make sure that collectively as a system, we had everything kind of pinpointed that was in scope. Because what we were finding is we'd have these meetings and everybody would have wonderful ideas, and next thing you knew, we had a scope of work that was growing by the day. So we just wanted to make sure that we had everybody's issues captured, we had all of the policy areas pinned down, and that everybody agreed that these are the areas that we needed to focus on as part of redesign within the timelines that we have established. So you can see on one side we have areas where we've got solutions identified. That doesn't mean that they are completely solved and on lockdown at this point. This means we've got a pathway moving forward that, moving towards resolution, and we're working that process through, and we think that we're solid once we kind of go through that pathway. Then on the other side, we have areas where, we're working on these issues. We don't have the specific pathway figured out, but they are within scope and we're working on it. So this kind of collectively shows you everything that we've got in play at this point and kind of what the status is as of today. So a number of them, pretty much all of these topics, you're going to get updates on this morning, so I won't spend a lot of time on this, but just kind of wanted you to know that every time we make adjustments or we add topics, or make changes to any of the policies, that requires us to go back and rerun all of our budget models and the rate assumptions. So that's why we're really wanting to pin down the scope so that we know how often we're going to have to kind of keep rerunning through those budget models. So I think this is a good list of where we're at today and what is included. So we want to spend a little bit of time this morning kind of walking you through one of the more significant changes and kind of a shift in the way we think about how services are coded. And I think this has been one of the biggest challenges for us to be able to kind of figure out how we kind of succinctly articulate this particular change. We are moving, and remember I had talked about scope of practice and really relying on what that scope allows a practitioner to do, and lining up coding with that individual practitioner's scope of practice. So that's kind of the backdrop for this particular slide. So for physicians or their equivalent, advanced practice nurses, physician assistants, as well as licensed practitioners, they will now be using, with the new code set, CPT codes for the services that they are providing. So this again is consistent with how the rest of healthcare is coding. So if they're physicians and licensed practitioners, that is the code set that they'll be using. And you can see if you look at the coding chart, the significant number of codes that we are opening up for those providers. So for those of you that are very familiar, probably everybody in this room is familiar, we have maybe 12, 15, 16 codes right now that we are using across mental health and substance use disorder to support the entire community benefit. So now we are opening up these codes to better be able to really show who's providing the service, what the particular service is, and then making sure that we've got rates attached to it that folks can understand, and that kind of line up with where Medicaid is. So they'll be using the CPT codes for the services they're providing: assessment, psychological testing, the therapies, crisis service. So this is kind of just a quick list to give you a sense of, for those services using CPT codes. Now what I can say is we get a question frequently, well, what if they're doing service planning, or it's an intervention that's not necessarily therapy? So we did identify a month or so ago that we probably have some gaps. We do have some gaps in terms of the CPT codes that are listed on the chart that you have. So we're in the process now of going back through and making sure that we do have a full code set that represents everything that the licensed practitioners or physicians are doing in the system. So I just wanted you to be aware that we're looking at some additional coding to be available for this group of practitioners. So then the middle row of practitioners, those are the unlicensed practitioners, and by unlicensed, meaning those with master's degrees or bachelor's degrees with the required experience. So master's level will need to have a year's experience, bachelor's level will need to have 2 years of experience, but the services that they are providing, and you can see those listed: the development of the treatment plan, service planning, collateral contacts, any sort of counseling that they may be providing. They will need to use a HCBS code, and that is 2019. So the service that they will be providing in the individual task will fall up underneath the therapeutic behavioral services. So that is their code. And noting that collateral contacts are allowable under TBS for that level of practitioner. Then the third row across the bottom is related to the unlicensed, and those that don't have the master's or bachelor's, that would be high school graduates, for example, or the master's and bachelor's level that do not have the required years of experience. So for those practitioners, they will be able to bill psychosocial rehab for implementation of the treatment plan using H2017. So this is the backdrop and kind of the restructuring of how we think about the coding of the services provided by the individual practitioner level. The one thing I will note is for the H2019 and H2017, nurses are able to bill those. We're going to be updating the slide. We noticed that we had left the nurses off, but there's subsequent slides that you'll see today that will address the use of those codes by nurses. So moving into some kids-specific topics. We have a group of folks that have met several times to kind of tease through and make sure that we've got all of the issues identified and start unpacking the issues associated with the delivery of services to kids and making sure that we have everything kind of adequately accommodated and make sure we've got our policies square. So you can see on this slide the variety of topics that we have been working through with this group of stakeholders that range from respite to high fidelity wraparound, the use of evidence-based practices and crisis intervention, and so these probably are not surprising to folks that have been working through each one of these. So we'll get into detail on all of these. Crisis, we've got some information that's not kid specific, but certainly the kids issues have been part of the conversation there. Partial hospitalization and day treatment was a huge topic that we are in the middle of continuing to work through, and making sure that folks really wanted to see kind of a separate day treatment service from partial hospitalization. So if you've looked at the recent slide set, we weren't able to update it since we just had the meeting on Wednesday. We weren't able to kind of get this particular set of slides updated, but information is available in terms of the proposed code structure and initial draft rates that we've put out. So we're working through those issues as we speak. So I'll just go ahead and move ahead. So related to high fidelity wraparound specifically, I think both Director McCarthy and Director Clea are very, very supportive of bringing high fidelity wraparound into the Medicaid benefit. So I wanted to say that up front. But as we started looking at that evidence-based practice and really understanding the level of fidelity and where we wanted to go with this, and hearing from stakeholders that they really want to use the high fidelity model, and then understanding and building upon the work that's been occurring through the Engage System of Care grant. We think we've got a pretty strong foundation, but we need additional folks in the room for this conversation. So it extends beyond the folks that we are typically working with in the redesign, and it's going to take a little bit longer than the timeframes that we've established to move forward with the rest of redesign. So that is a project that we are going to put on a separate track of work and a separate timeline so that we're able to adequately address all of the issues. I think folks do provide pieces and parts of wraparound now that they can get some Medicaid reimbursement for, but I think the overall goal is to have wraparound, have it be something that's done with fidelity to the model and that is adequately reimbursed, not just kind of the components of it. So we want to take a little bit more time to make sure that we're putting together a model that's the model that the state wants and that is paid based on that. So that'll be something that we'll be putting on a separate track with a longer timeline associated with it. For respite services, Medicaid does currently have, through managed care, a waiver approach for a pretty specific set of kids. So Medicaid has agreed to take a look at the existing waiver and be able to expand eligibility to kids that have behavioral health needs. So we're kicking that work off. We've worked with our stakeholder group. We're getting recommendations for them in terms of criteria for kids to have access to this for the respite service, who eligible providers might be, what respite settings would be appropriate. Right now, that waiver is specific to in-home respite. So are there other settings in which respite should be provided for these kids that would make sense from a behavioral health perspective? So we are working through all of those issues with a group of stakeholders, and we are targeting that work and have that available, again, target for January of 2017. So we're excited about that particular piece of work as well. And then for early intervention, and what I mean by that specifically for the next few comments I'm going to make, we're talking about services for young children, the 0 to 3, 0 through 8 perhaps. So the context is for this was the little kids, but folks wanted to know, we kind of picked apart, is it that we need new programs, we need new services for these little kids, like where do we need to go with this? And the long and the short of it was, folks kind of realized that we don't necessarily need new services or programs. There are administrative barriers that preclude folks from accessing the services. So one of those barriers that folks felt precluded folks accessing services was related to qualifying diagnoses and having to give young children diagnoses to be able to then receive services. So one of the brand new updates that you don't have in this slide deck is that we will, for behavioral health services provided to kids actually birth to 21, there will be no Medicaid edits and MITs associated with diagnosis. So this doesn't apply just to the little kiddos. So this is birth to 21, no edits. But with that being said, the diagnosis has to be determined by someone who is able and authorized to render a diagnosis in accordance with their scope of practice. Services must be medically necessary. In addition to that, we need to, the diagnosis has to be, or the service has to be related to the diagnosis and appropriate to the diagnosis as part of medical necessity. And as always, services are subject to post-payment review. So we think that this is another really good change as we're moving forward, particularly in terms of allowing access or expanding access to those early intervention services. And I know, Cicely, do you want to provide your
my little tidbit?
Your little tidbit, yeah.
And also just a reminder that the ICD-10 codes for behavioral health services are expanding come this July. And looking through them, there seems to be a lot more that can apply to younger kids, so there's going to be less restriction on trying to find a diagnosis.
So another issue that came up in the kids group was related to psychological testing, which then also led us down a path of, what is the policy associated with the delivery of services by school psychologists. So on this slide, you will see 4 codes related to psychological testing. These codes have been available through Medicaid for a while. These have been codes that have not been available to community behavioral health providers. So we are going to add these 4 codes to the code set moving forward. So community behavioral health providers will have access to billing for these services. So this slide gives you a little descriptor of what those codes are, what the associated rates are. So one thing to note, these are the same rates that anybody else who's able to bill for these services under the Medicaid program, that's what they get as well. So again, kind of standardizing the coding and the rate structure. So I just wanted to point that out. So we think a number of these services probably have been provided, in the system for years, but now we're able to actually have the discrete coding associated with those. So. And then I will turn it over to Cicely, who is our expert on school psychologists.
Expert is a strong word. So us at the state needed some clarification on the different types of school psychologists operating in Ohio. So we actually met with the president of the psych board and with a board licensed school psychologist and kind of walked through. And we thought perhaps since we needed the clarification, maybe it would be helpful to you as well. So there are 2 different types of school psychologists operating in Ohio. The first is with the Ohio Department of Education certification. These school psychologists have a master's degree in school psychology, and then they're certified by the Board of Education to operate within the employment of a school board or in a private school that meets certain ORC standards or in a program for children with disabilities. All of the references are on there if you want to look into them further. But for the purpose of operating in a community behavioral health center, these practitioners will operate as psych assistants, school psychology assistants. They will need to be registered with the board and will need to operate under the supervision of a psychologist or a board licensed school psychologist. The other type are these board licensed school psychologists. They also have a master's degree in school psychology, but they have to have 4 years of experience, which includes their internship. They have to take the praxis, and they have to pass an oral exam. Once they do this, they're licensed by the psych board, and they are independent board licensed school psychologists. They can operate pretty much anywhere, in a hospital, a private practice, or in a community behavioral health center as an independent school psychologist. Unfortunately, right now, Medicaid does not enroll for the independent licensed school psychologist. This is an issue that's been raised to us, and we are currently working to find the quickest way to get that enrollment up. It's quite a midst build, so it kind of takes a little bit of time, but we're working on trying to find the fastest way so that you can start enrolling and billing Medicaid independently. We will let everyone know once we know for sure when board licensed school psychologists can start enrolling in Medicaid.
All right, as part of our small work groups, we had to convene one on crisis services. And at one of our preceding meetings, probably two or three ago, we talked about this with our benefit and service development members. And we were talking about it in the context of the two groups of practitioners, the licensed and the unlicensed. On the left-hand side, and thematically this goes along with our operating at the top of your licensure or your credential. Licensed practitioners with crisis can provide crisis services to individuals independent of whether they're actually on their caseload or not. It's within their scope. They actually can provide the service whether the person is actually a patient or consumer at the agency, because they're operating under their licensure there too. I'll say a little bit more about that in a second. But now this is moving into our CPT realm. When they provide that, they actually have two codes available. And can I see a show of hands again on who went to the CPT trainings? Okay. So our facilitator there explains about the difference between a CPT code and an add-on. So anything you see with a little plus sign is an add-on. So it has to come in connection with the base code. And this is a good slide to explain that. So in this instance, the base is the 90839. And then for each additional 30 minutes, you can add that 90840 as needed for the licensed practitioners. We have a little footnote here because right now, even in the context of the department, so DATIS and ODMH merging and becoming one, there was a difference. On the mental health side, crisis services were lined up with what you see here on the left-hand column. On the SUD side, it was not. You actually had to have the person being a patient and assessed and admitted to the agency. With this change here, we're getting that corrected to line back up with the actual licensure and practice. So we're fixing some other things along as we go along here. We then also have our unlicensed practitioners. They have to work with patients who are known to the system. They have to be on their caseload, and the recommended care, which naturally should include crisis, needs to be available. And then for those individuals, we are working with the H code since they right now can't use the CPT codes. And kind of the earlier slide that Angie did, they have available the therapeutic behavioral services. This one says IITS. We haven't got that completely fixed yet. Or the PSR, the psychosocial rehabilitation. And then for the SUD patients, they can use the individual counseling and hold the thought on IOP. We're still working through there, but they would have other H codes as needed available, and we're making sure that we're kind of filling those gaps. As part of the discussion with the group kind of post this, we set out and we talked to them because people were identifying that there were things missing. A lot of what came out wasn't necessarily just the direct crisis service, but it had to do with indirect costs that were associated with it, meeting the person where they're at. They brought up things like transportation, taking person from point A to point B. We were presented with one example of they may have to transport almost across a county, and when you get a transport entity involved, they'll pay from A to B, but they don't pay B going back to A without transporting an actual person. So we've talked about that. Additionally, what came up was the concept, and I think Angie mentioned earlier, about consultation. They may be getting in touch with other practitioners, arranging care, and we are looking at some additional coding around that to represent hopefully those consultation activities. These are some short-term things. Longer term, people talked about actually mobile crisis and the concept of urgent behavioral health care centers. Those are two much longer term projects for two reasons. One, they cannot be fully funded under Medicaid, because when you set those up in a community, the concept of urgent care is people will come, or mobile that you will go, and you can't necessarily restrict that to just the Medicaid population. So we have to work with other payers in the system to actually fully support those types of crisis delivery models, if you will. Excuse me. Longer term, so I think that what we've done is that's going to be another kind of one of those longer track. You know, that I mentioned the transportation, people have brought that up, how do we cover that? But that's kind of a non-Medicaid related activity there we'll have to look at. They've brought up models where they've partnered up in the communities with hospitals, so we're doing some more around there, and actually just general capacity in the communities there. Evidence-based practices for mental health populations. In your packets that Sherry and her folks have provided, on the left-hand side, mine are in color, I believe yours are in black and white, but for a moment we're going to talk about these two fidelity scales. And as short background, when we undertook this back and started discussing about mental health services and evidence-based and best practices, you know, two that always percolate to the top are assertive community treatment and intensive home-based therapy. We also had extensive discussions with our work group around other EBPs, such as multisystemic therapy, functional family therapy, parent-child interaction therapy, PCIT, that's the acronym for that one. And after a couple rounds, we kind of, as a group, came to the conclusion, like, we're picking and choosing a couple out of the myriad of evidence-based practices that are available. And within the coding change of moving to CPT codes, the practitioners that are doing this actually, as long as they're trained and they have the competencies, they can actually do those and they fit underneath the coding structure. What we can't do is actually pick out and try and build a rate for every single one of those models of care. So it's not that they're prohibited. They actually can and should be done to the extent the patient needs it and the clinician is trained, with the exception of our assertive community and treatment and intensive home-based therapy. Those we are building for the implementation into the new code set. And to do a quick dive on those, if you look at the assertive community treatment, and we won't pull it up here, but if you look at what you have in front of you, it has a special payment structure, and I'll talk about that in a moment because it is confusing and complex in and of itself. But in order to have an assurance that an ACT team is operating at a certain level that meets, you know, qualifies them for the payment, the only thing we have to do to have available to do that is the fidelity scales. And the one that you have is the Team Act, the tool for the measurement of ACT. We also do have the DAC teams operating, and we're working on how their requirements to qualify for the payment. But for this, what you see is where we have set the base requirements. I won't review all of it. You can read that at your leisure. But overall, they need to qualify with an average of a 3.0. But if you go and also look at the first page, you know, we have, in consultation with CASE, who's our ACT Center of Excellence here in Ohio, consultation with Mercer, who has done work with many other states in implementing ACT as a model of care and associated Medicaid payment. We've also had consultation with other states and consultation with Dr. Lorna Moser, who's the author, if you will, of this, which builds off of that ACT. And within there, we've arrived at, underneath even that average 3, there are some areas where we are setting minimums to qualify. So just as an example, on operations and structures subscale 1, the low ratio of consumers to staff, that we will be requiring to have at least a 3. So 14 to 18 ACT participants to staff. So you can go down and look through those and see where we've set some specific ones. I think there is only one that's higher than a 3, but we are working on the mechanics, if you will, of how a provider who wants to get into ACT and actually use the ACT billing construct, how they would communicate this to us, a validated fidelity review, and we would set them up to bill for that. So now for the really complex part. ACT in this construct is not an actual service. It's a model of service delivery, comprehensive to the individual. That doesn't fit well in a fee-for-service model. You know, service delivered, bill for it, get paid. You know, theoretically you could do that today, but there are other things that the ACT teams do that don't necessarily fit that. In the fee-for-service model that we're still operating in, you can't go to a full case rate payment either. So we have to come up with what you see here, which we call our hybrid payment model. And if you go out on the website, I think around February 12th is when we reviewed this. There's a lot more information there you can look at to do this. But we picked out one model. This is under the Team Act, what we call a small team. It's got the lowest number of patients to the team. And because under Team Act, you can have 2 prescriber types. You can have the MDDO or the APRN. There's actually two billing constructs. So we'll go down the left-hand side first. And what you see are the proposed unit rates. We've not done any work on re-engineering those at this point. So what you see is where we're at. So there's an expectation that the ACT team members are continually interacting with the patients. So when we move out of this, you know, bill for every discrete service and into the billing or payment for the team members for the month, each of the practitioner types qualifies for 1 billing per month. So in the case of the MD or DO, when they actually interact with the patient face-to-face, these have to be face-to-face in order to actually support the billing, they would be able to bill the 1 unit, and they would use the H0040 code. I know that's a little different than CPT, but we have a different payment model here. And that would then draw down the $662.60 for that month to help cover the cost of that practitioner. We also have rates then for masters, the bachelor's level, and for the peer recovery supporter. And we have a slide later on where we'll talk a little bit more about peer, because it actually sits in a number of different places in the Redesign model, not just in our specialized recovery services program. There can be a 5th unit billed under this model, Team Act, for bachelors, because Team Act has supported employment in it also. So there's a lot more detail on the website if you want to go and read that. So each one of these would result, and you see the total at the bottom, of the team bringing in almost $1,600 to help cover the cost of the team-based care. We go over to the right-hand side in the instance where the prescriber is an APRN. That rate is different because of the different level of practitioner, but they can still do the whole billing construct there to pull down the fee-for-service hybrid payment for the team for the month. So our next one is IHBT, intensive home-based treatment. And because this one is a state best practice, it's not a full nationally recognized evidence-based practice, we did our consultation with Case, who's our IHBT expert here in Ohio. And what you see here are their recommendations. The state team also met, and with some of the other criteria, we've laid out a few others where the state would make certain requirements. Again, this one is a little different. It's not a team-based, but it's a unit-based 15-minute service that actually has its own payment rate. It's a master's level rate because we only are accommodating master's level clinicians in here. Again, we're working on the mechanics of how a provider would demonstrate this to the state, submit it so that we could actually turn the special payment mechanism on for them. But in addition to that, we are working under the assumption or the mechanics that this one will actually be a fully prior authorized service. So even if the rate is turned on, if the service isn't prior authorized for the patient, it won't come through. Because this is a targeted, short-term, 6-month service, high-intensity, community-based service to children and their families. And this was even supported and recommended by CASE that we take this avenue to help just manage the service itself. So there will be much more to come on those two. Our next little section here is, who's our SUD providers in the room again? Okay. I'm assuming most of you, if not all of you, are familiar with the American Society of Addiction Medicine criteria. So as part of redesigning our benefit, and I kind of take a step back, it was interesting. If you go, there's a Centers for Medicaid and Medicare Services letter around a program they have called the Innovation Acceleration Program. This letter was published by them back in, I think, July of last year. And it's a technical assistance opportunity that the feds have for states that are undertaking, either implementing or, like we are, a redesign of their SUD benefit. I have to go back even 6 months ahead of that letter. Back in January of 2015, a number of our state teams actually had a consult with CMS. And it was kind of in advance of this letter and their implementation or opening or starting the Innovation Acceleration Program. It included John O'Brien and staff from his office. And we laid out what we were working on very broadly and in scope. And it was very interesting because their response back to us was, we don't suggest Ohio take advantage of the IAP because you are already ahead of the technical assistance and what they were offering. So we did, in our work group, we reviewed the letter with everybody, and even the work group came to the consensus that we were already down this path, and to pursue anything there at this time would either slow us down or detract us from the work that we have available. But one of the interesting things in the letter was the ASAM criteria. So I think that's, these are just examples of how we got there. What ASAM is a pragmatic way of evaluating 6 dimensions associated with an individual. There are intoxication or withdrawal potential, biomedical associated, medical conditions, emotional, behavioral, and all the way down there through recovery and living environments. So that's across these dimensional looks, you come up with levels of care. And let me flip up. Within our redesign project, we are looking at the levels of outpatient all the way up through residential, like you picked up on. We are not using or looking at the level 4, the medically managed intensive. That's hospital-based care to us. That's not community care. So we're not looking there. Angie talked a little earlier about the mental health and the early intervention. And this is an interesting place where terms get used, although they're not quite the same thing. There is an early intervention level of care, but because we actually don't have that in the continuum today, we haven't done a foray down into that level yet. But we are going to be looking at and bringing into use the levels here from outpatient, intensive, partial, through residential. Now, this one can be a little confusing. Anybody here familiar with the currently CMS-approved SUD state plan amendment for the state of Ohio? I am. If you go and look at that, and it's available publicly, you will see that what we did a number of years ago is we cut and pasted the certification standards into the state plan. So for every service, you see its definition. It has the class and qualified practitioners of who can do what. We are totally breaking away from that model. In our work group, when we brought the SUD state plan amendment out, the new one, what you see is outpatient and residential and some things underneath it. You can't go there and see each and every unique service anymore. So it's a real big paradigm shift here. So when we do that, it gives us broad authority and flexibility to make adjustments without always having to go back and petition the state or petition the federal government and negotiate with them. But it also means then we actually have to provide a lot more guidance and policy direction to the field. And actually in this slide we're missing one. We should have a thing in the middle that talks about rules. So when we have that flexibility on the state plan, we then have to do things in rule to implement or put real requirements. But practically for the field, we have and are working on a provider manual where we give really the nitty-gritty, the stuff that you need to pick up to be able to understand and provide services. So when we do that, we've actually brought together even the mental health and the SUD benefit into that manual. Has anybody seen the draft version? Yeah, I think it had, the last one we put out publicly was in October, so it's even out of date, but in the interim, we've been working on updating that. So it's been an interesting mindset set change for us to go to this more generalized state plan and then have to do more of the policy and the implementation through rule and through manual. So we're working on all of that stuff in the background to help support the changes. Now, let's jump to residential for a quick second. This is what some of us who have been around the system for a while refer to as the hidden benefit today. We don't actually pay a per diem for residential. Technically, we don't have residential coverage. Some residential providers will use the menu of services today to provide and bill for those services, but in the future, because we're modeling around ASAM, we're actually working on developing per diem rates for residential services from 3.1 through 3.7. So there's 4 levels. There's also 2 withdrawal management levels in there too. This is a significant change. We actually have a small committee of representative residential providers or interested providers too. And as Angie mentioned earlier, we did some targeted work with them. We have actually put a survey out to them. So thematically, we've been using surveys to garner a lot of feedback. We actually have in the manual staffing expectations. Those do not come directly from ASAM. You won't go to ASAM and it'll tell you, clinically managed residential low intensity that you have to have a physician. But for our purposes of building models, we have to have staffing expectations. So we're comparing what's going on in the state today to those expected staffing models.
We found in the manual.
Yeah, that are in the manual that are actually built off of work from another state that was done in consultation with Dr. Mee Lee. Dr. Mee Lee is over ASAM, if you will. So there is a connection. So we're working with them and we've done the survey. We've gotten, I think, maybe 15 to 20 responses. We've handed those over to Mercer, the actuary. They're reviewing them to compare, and we will be getting back with them. And if we make any fee adjustments, Angie mentioned earlier, those have to percolate through the whole budget model to see how everything else kind of shakes out. So we're working that as a small group that's dedicated on an SUD topic. We do have another one. Do we have any OTP representatives in the room? Opioid treatment programs, thank you for coming. We also have a former SOTA over here. I will point you out, Bradley. State Opioid Treatment Authority. On February 26, Director Plouk received a direct request from the opioid treatment programs. For folks who have no background on them, they are the methadone programs. They have been in existence since 60s, 70s. I'm not even sure it predates me. But they are the most regulated service line in our industry, if you will. Now, in Ohio, regulation-wise, our department licensed them for methadone. They also have a federal recognition under SAMHSA, which also allows them to to administer and dispense buprenorphine-based medications, even though the state doesn't recognize it. So in part of this redesign, they asked and said, hey, this is part of our scope of practice. Can you put something in place so we can actually provide and use another medication for the population? And it makes a lot of sense considering what's going on in Ohio. So we're working with them directly to accommodate that request and with an administration code and figuring out how to cover the medication itself. They also put a request in there, and I am way out of my comfort territory when it comes to talking about monitoring QT intervals. But for patients on methadone, it's monitoring their heart. And today they cannot have covered when they do EKGs, ECGs. We will be opening that up to them. They will need to do it in context of their cardiac risk management plan. But this also is one that actually got broader because there's also that level of monitoring for patients that are on certain mental health medications. So we're actually bringing it online for both business lines, if you will. So we have a draft reply to the OTPs. It's actually out of date, but if you want to go and look at it, it's online. But it's another area where we're modernizing and updating the benefit. All right, so we've talked about, Angie did on the timeline, the change come January 1 for all providers of ceasing to use 90863 for mental health farm management and H0016 for the SUD med somatic. So what we have here on the slide is actually the codes, the CPT codes that you will need to begin using in place of those. So Angie mentioned about the evaluation and management, E&M codes. Those are the codes here on the left side. And this was used at a point in time for budget modeling, which is why you see the 2016 Medicare rate, and I'll say something more about that in a minute. But you can also see there's a set of 5 for new patients and a set of 5 for established patients. So anybody who came to the CPT trainings would have been, you would have been exposed to the difference between when it's a new patient versus an established patient. These codes are not time-based. They are actually level of medical decision-making based, driven by review of systems, history of presenting illness, all of that. I cannot even do justice to the training that Diane did for us, so I would encourage you, we are posting that to the website. It's not available yet because we have to cut it into 1-hour chunks, give or take, to get it up there. You also see in the red box there where this is used independent of your patient's condition. So there's no longer one code for mental health patients, one code for SUD patients. You just use the appropriate CPT code for either or both. But also when we go to this evaluation and management, I mentioned earlier the little plus signs that are the add-on codes. Those are the codes that you see on the right. So to give the layperson's example of this, in the context of a physician who's seeing an established, fairly high acuity patient, they're looking at something in the 9921314 range. If during the provision of that service, they actually start doing full-blown psychotherapy, so they actually, for whatever reason, need to kind of stop the medical and actually shift into psychotherapy, depending on that length, I think those are 30, 45, and 60 minutes. They can add on that psychotherapy code as long as they've documented what they've done. So they would bill, just for our example purposes, the 99214 plus the 90833, and they actually get paid for both of those services. Then when we add the psychotherapy into there, there's another code that adds on to them. So we have an add-on to an add-on, which is that interactive complexity. That does not add on to the medical service, it only adds on to the psychotherapy service. And there are documents that you can get about that, but it has to do with The example I give is accommodating. You're seeing a patient, maybe their spouse, and it's a little disruptive because there's some conflict between them. Things like that get into whether or not you can do the interactive complexity. Then there are also these other two services which are prolonged service. And again, I will refer folks to the CPT training, but in the instance where the office visit actually does turn more into an extended time-based, you can add those prolonged service codes onto it also. So this is actually the required transition code set, if you will, for January 1. So the next couple slides, if all a provider does is do the requirement for January, for mental health services, these are the codes that you would continue to use. So this is the quote-unquote remainder, if you will, of the old code set that you have the ability to use through January through July until you either voluntarily make the transition or are required to transition. So then, we just do another example of a slide here on the codes, how they match to the practitioners, the services that they're rendering. We also have down here at the bottom, I will point this out, that when we started looking at the CPT codes, there was a gap identified for RNs and LPNs, or nurses. So they in CPT world can only do the 99211, so we had to find additional coding, and we actually filled that in with the H2019 and 2017. I will say more on that in about 3 or 4 slides. So I don't want to kind of gloss over that, but okay. For the SUD side of the house, if all you do is the required change come January 1, here's the remainder of the code set for all the other services that you're providing. This is, the remainder of the quote-unquote old code set. And then for illustrative purposes, this chart is actually exactly the same whether you look at MH or SUD, because we equalized that coding structure there. And even though we don't do time with the psychotherapy add-ons, if you note right there in the middle, so for the 90833, you have to actually provide the psychotherapy for somewhere between 16 and 37 minutes to actually add that on. You cannot use those codes if it's under 16 minutes, so you have to pay attention to that. Right. I mentioned earlier that there was a gap identified around our RNs and LPNs because they can only use the low acuity, established patient, no medical decision making, no need for the physician to be involved. So we did a lot of work, and you actually will see the codes that Angie talked about on the therapeutic behavioral services slide here, where they actually are able to be used by RNs or LPNs. The LPN uses the 17 and the RN would use the 19. They should use those only in instances where the 99211 does not apply, and I will give a very clear one. The 99211 is office-based. The patient has to come to the office to receive that nursing service. It cannot be done in the community. So in the instance of an RN or LPN that's going out maybe to a patient's home, that is a clear-cut instance where they would have to use the H codes because the 99211 cannot be used in a community setting. We also, to finalize this arrangement, we actually have nursing-specific rates, RN and LPN specific rates for these two codes. Now, people may say, well, how do you figure it out? Our RNs and LPNs are enrolling as a rendering provider. So as long as they bill it under their NPI as an RN or an LPN, the submits is being engineered so it would pick up the applicable rate that covers their nursing activities. So kind of like the discussion about education, we don't go through every single variation or every single service, if you will, that the RN and the LPNs can do. And I forgot to mention this, we actually did consult with the nursing board a couple of times around this to make sure that, in what they're doing remains within scope of practice. We do have a qualifier up there. A full, actual, true nursing assessment can only be done by the RN, and LPN cannot do it. But the other two examples, the med assessment, education, and symptom management, can be done by both an RN and or an LPN. And again, on the right-hand side, they should use the 99211. Otherwise, if it's something that does not meet that, then they can use the H code. We also do recognize that the LPN needs to be supervised by a higher level practitioner. Now, sometimes these have gotten a little bit out of context, so the code set that I talked about is the required January 1 remainder of the old code set. If a provider wants to go to the new code set, it's coming up, but we want people to be aware that we didn't lose anything, but this is where we've just gone through. If you don't make any other change other than what we're requiring, in the new code set, there's IOP, ihbt codes. The psychotherapy codes we talked about were add-ons. There's actually standalone codes there. The psych testing. And I think that's one of the things that we've tried to educate people is that a lot of the expanded coding, labs and vaccines, will not be available until you actually switch to the full new code set. So you need to consider that as you're going through this. I mentioned the labs and vaccines, and office-administered medications are in here too. Part of, and Angie mentioned earlier about extending our integration efforts between physical and behavioral health care. When you start looking at the medical practitioners that we have in our field and the way that we have coded things in the past, they don't line up. So as we've made this transition, particularly around the evaluation and management codes, there's a broader healthcare aspect that they bring to the table. So we've put two very basic scenarios up here to try and demonstrate the furthering of the integration. So the first one is a child comes in for a scheduled appointment with their parent or guardian, and it's picked up that there's no evidence that they had their mumps, measles vaccination. And what can you do in the future? You can discuss that with the parent and actually offer to give them the vaccination there. You will have to get the vaccine itself through the Vaccine for Children program, but if you're picking up on a medical gap, for want of a better term, you can help fill that. Our scenario number 2 is that an established patient, in this case a female, comes in for a regularly scheduled appointment and reveals that she thinks she may be pregnant. Well, what can you do? You would do your practice of discussing pregnancy in relation to the medications and the mental health condition in this case, and offer to administer a pregnancy test to her, like a medical or like a general practitioner could. So the pregnancy test is now a code in our lab and vaccine chart, so there's coverage of that. And the reason that we are doing this is we actually have medical practitioners who have medical backgrounds who are applying sound medical judgment and helping to manage and monitor their patients. And it's a very appropriate thing for them to do, and we want to be able to support them in caring in their practice. All right. Clinical Laboratory Improvement Amendments, Clea. Anyone familiar with that? A few folks, thank you. You may even probably are more familiar than I am. I always like this one because Clea is a federal regulation that requires any facility that performs testing on human-derived samples, so urine, saliva, hair, biopsies, anything that comes from any one of us has to be operating either under a Clea waiver, which is that first level, and I'll talk about that in a minute, or another level of Clea certification all the way up to the high complexity lab, which is that certificate of accreditation. So examples of what can be done under a Clea waiver is the pregnancy test. It's in office, it doesn't take any actual lab testing, if you will. Other things are, blood, when they draw blood and send it out, when you actually do a urinalysis type of testing and it goes to a lab. And in the SUD world, it could be point of service urinalysis that we're working on, the office administered cup with the instant reads, and the confirmatory testing that then is sent to the lab. If that's done, would actually bill directly to Medicaid by the lab itself rather than being embedded in the fee. So we are encouraging folks to take a look. Oh, I do make a side note. We added an additional medication in there, which I think is injectable Abilify. That was done at Dr. Hurst, our medical director's request, in consultation with Dr. Applegate. So we're encouraging folks to go take a look and see what's available there.
So as Angie stated earlier, starting January 1, Medicaid is going to be turning on the Medicare edits. This ensures that did I say Medicaid? I don't remember. The Medicare edits, we'll repeat it just in case I said it wrong. This ensures that Medicaid is the payer of last resort, which is a federal requirement. So first off, if you are not seeing any Medicare patients and you know that you will never be seeing Medicare patients, you do not need to worry about this part. But anyone who's seeing Medicare patients or could in the future will need to participate in Medicaid. Medicare. So this means that starting January 1, Medicare needs to be billed first before you bill Medicaid for Medicare patients. This is the same for any third-party payer. So there's two different ways you can work with Medicare. There's Medicare certification and Medicare participation. Likely most of you will be doing Medicare participation. Medicare certification requires a lot, site visits, certain staffing requirements, and there's a lot of legwork that's required to get fully Medicare certified. It's going to be confusing on the website because for Medicare certification, it asks you to enroll as a CMHC, but really just to participate, and simply what we need you to do for January is Medicare participation, which means you will enroll as a group practice. So I would just encourage you to look at the Medicare website and get enrolled, because starting January 1, it's a requirement. Any other things about that? These are, if you look up here, these are the practitioners that need to be enrolled with Medicare. Also, the agency itself has to be enrolled with Medicare, so it's not just one or the other. So that's just your physicians, your advanced practice nurses, your physician's assistant, your psychologist, your LISWs, and those are the only ones that Medicare recognizes, so those are the only ones that need to participate with Medicare. For everyone else listed below, you can continue to bill Medicaid directly. All right, so that leads into the discussion of rendering provider. Also starting January 1, we are requiring there to be a rendering provider on the claim. This is what we're doing in other areas of Medicaid, and we're just now bringing it over to the behavioral health world. So this means that everyone on this list, which will be your physicians and your psychologists and then your independently licensed practitioners, including your RNs and LPNs, will need to get an NPI if they don't already have one and enroll on the Medicaid website as a Medicaid provider. Then when a bill comes in for dates of service on 1/1/17 or after, the rendering field will have the practitioner's NPI, and then the billing field will continue to be the agency's NPI. There are a few caveats that we're still working on. LICDCs actually cannot start enrolling until this July 1. When we brought up all the other independents, it just got delayed. So starting July 1 of this year, LICDCs can enroll. Also, we have had many people bring up the fact about dually licensed people, someone who might be an LICDC and an RN. We're working on the solution to that. Likely it's going to be enrolling with a specialty, since we don't want you to have two NPIs because that defeats the point of an NPI. So likely what you'll do is you'll get on and you'll enroll as an RN with a specialty of an LICDC. But we'll get you more information as we know about that. If you're already enrolled, you'll also be able to call and just add a specialty. So we'll get that to you as soon as we have all the details hammered down. Also, prescribers who are already enrolled as ORP will be doing a mass transition for rendering, so you don't have to worry about that yourself.
About Lincoln.
Oh, yes, thank you so much. The big thing that I totally almost forgot to say was that agencies need to affiliate all of their rendering providers with their agency. That means they need to go on to MIDS and connect them saying that they are affiliated. A practitioner can be affiliated with more than one agency. That is fine if you're just contracting with them, but they need to show that they are connected so when the rendering and the billing match. Also make sure to, if they leave your practice, to unaffiliate that practitioner. So when it comes to people who are not able to enroll in Medicaid, they will use a modifier as their to differentiate their education level, and we're working on the details about that. But they will not need to put their MPI on there as they won't be enrolled. So.
Starting this section, we're going to talk a little bit about draft budget models. The documents we have in the PowerPoint are available on the website. They are out of date, but we wanted to take an opportunity here to talk about budget modeling and budget neutrality. So anytime you undertake something on the scale that we are with the redesign, we go through an exercise of what effect do these policy changes have around the financing. So we took a complete fiscal year 14, all the community mental health and all the community SUD services, nobody's billing them anymore, so it's a stable year. And we can then begin to build assumptions, build the rates, look at utilization, and see the effect that all has if it had been implemented in that fiscal year. As I said, in this case, fiscal year 14. Kind of preemptively, we generally get the question, well, Medicaid expansion came online in January. Yes, it did. And it's accommodated in this exercise because the utilization for those individuals is in here. It's not tied to the person per se, but it's tied to the delivery of services. That's a very different thing than looking at projecting forward for future financing. So we're not at that point. We are just at the point of evaluating this against a actual closed fiscal year. When we shared this with our work group, actually our Medicaid's actuary, Mercer, did this. We had been charged by Director McCarthy to come up with a budget neutral design. So no more, no less than what had been paid. So when we've been talking up here, and we'll talk a little bit more about the rates later on, there's a big distinction between CPT rates and the HCBS coded rates. We don't actually go through an exercise on the CPTs of developing actual rate methodologies for those. Those already exist. It's used by Medicare to develop their rates. In the Medicaid world, Medicaid cannot pay more than Medicare. So what we can do is work from the Medicaid rate to look at choosing different rate options for the CPT codes. But we can't go over the Medicare. But on the other end, with the HCBS codes, our Mercer, the actuary, actually has models that they use where they take inputs such as employee salaries, Bureau of Labor Statistics, estimated productivities, supervisory requirements, employee-related expenses such as health care, vacation days, all of that to develop and present us with rate bands. They range from 0 to 100% of whatever they calculated, so we call those fee ranges. So just as an example here, peer support was one that we worked on early because of the Specialized Recovery Services Program. So within the ranges of fees that Mercer presented to us, we landed on the 85th percentile for that service. I said earlier that we'll talk a little bit about peer later. It actually sits in more than just the SRS, but because we'd already modeled a fee for it, we're just applying that fee wherever that service can be billed. The individual and group counseling services that are referenced here at the point in time when this was presented were set at the 50th percentile of what they calculated. In the current system, we have a similar service, SUD and mental health, case management, and CPST. Those two are lined up now and actually share the fee, the current fee for case management. CPT codes outside of the E&M, interactive complexity and psychotherapy add-ons, when we did this, were presented at roughly 77% of the Medicare, which is 124.8 of the current Medicaid. So in these models, when we've upped the CPT code rates, and actually we have now maxed those out against the Medicare, our system for those services is actually getting paid higher than general practitioners. So we've done all that we can there on those, which is down here at the bottom, that they're at 100%. We've got no room to do anything else with those. They are maxed out and can't go anywhere. So, okay, trying to make digestible a big amount of numbers. You know, I mentioned earlier that we did the MH and the SUD services. You can see those, and then we combine them down here at the bottom. So in this budget neutral scenario, if you look to the bottom right, $802,605,012, there's a zero underneath it, which means we actually in this model hit budget neutrality. You can look up there and see where particularly mental health adults, you know, that's a negative. Things shift around within there, but in terms of the overall, it's a budget neutral model. At a point in time when we did this too, the children's mental health was a little bit lower, but jumping ahead to the next one, the directors got together, and because of some things that occurred in an earlier model, Director McCarthy committed an additional $10 million towards children's mental health services. So we actually now are looking at a budget plus scenario. So we actually have money above that to target in some areas. So when that was put back in, we went and said, okay, it's not really associated with any strategy in particular at this point, but you can see under the children, and it now says 13 million instead of the 3 million, or rounding would be 4. So we represent that there as an investment opportunity, and if you look at the bottom right, it now shows an additional $10 million down there over and above the 802. Okay. We have another that, in working through this, we've maxed out the E&Ms. We've left and aligned case management and CPST. We actually show you the peer and individual and group rates there. We have done some targeting around SUD group counseling. This was shared at this Wednesday. So if you go and get that slide deck, you'll see some slides in there on SUD group and IOP and partial. But in addition, down here at the bottom, Director McCarthy in the state has actually put another $25 million in the mix. So we now have an actual zone of $35 million to evaluate additional rate restructuring and changes, still preserving the $10 million for children's mental health, and the $25 million, you know, in part is helping us move other rates. So we have presented the E&M rates and associated add-ons. This is another cohort of CPT codes. And what we use this for is at our March 9th meeting, and if you get the March 9th rate chart, these are what you will see in there, which are on the right-hand side. We've gone back and bumped this cohort of CPTs up, which is pretty much all of them in here. We've increased them. You can see on the right-hand side what they've gone up to from the 24th to March the 9th. Okay. So we're using that to help bump these up. What I can say about the ones on the right, they are not quite maxed out. I think they're at 91% of the Medicare, so we have a little bit of room still in there. If we go back and look at making some changes there, but there's not a whole lot left to work with. And again, that's the nature of Medicare being the cap, if you will, that Medicaid can pay up to. We just showed the CPT change down there that did go down with aligning up with the SUD case management, and then all the other rates in that chart for the 9th were the same. We also pulled aside a small work group. Many of the provider representatives in the room and board representatives and other interested parties wanted to know a little bit more about how Mercer was actually doing this budget modeling. And actually, I think they helped in the discussion, help us do some pretty good refinements to it, and incorporated a lot of their feedback, looking at pathways that patients are taking to care, the conversion of what traditionally has been the bulk of HCBS codes to CPT codes. People often will ask how we did that. Well, in the spirit of this, we did a survey out to providers and said, to help us do this, we need you to tell us, your staffing. What's your group of licensed, what's your unlicensed, what's your medical personnel? So based upon that feedback, put together at a higher level, Mercer then takes what traditionally to them looks as an unlicensed service, H code, and then can begin to pull that out and go, okay, maybe 50% of this goes into the CPT world and 50% of it stays in the H world based upon the mapping. So provider feedback has helped us refine this model again with this coding, where we don't know the practitioner that's in the mix there. So staffing and practitioner client ratios, we've done looking at hours of programming, the community versus office-based services, frequency of use, and obviously providers are quite interested in the cost. We have intentionally not released additional budget models just because we actually run these, I would say, fairly regularly. We are probably up to model version 13 or 14, something in that realm. So we are continually doing this. We actually have to start all the way over when we make policy changes and assumption changes in there and rate changes. So we keep this going in the background as we're refining and finalizing this work with the Mercer and the budget modeling. All right. Code and rate chart. We just want to make sure that people know where to actually go and find it on the website. It's not as intuitive as it could be. It doesn't have its own tab, but if you go on the website, you go on the About tab, you scroll down under the core team materials, that's where we post it. The current one is March 9th. It has not been updated and reposted, and that's for a couple of reasons. As we continue the rate refinement, the code identification refinement, and building this out, we've actually are trying to make this much more of a useful tool for the field. Right now you can XY plot it. You go find the practitioner, find the service, you'll find a cell. There may or may not, there may be a rate in it, or it may say NA. One of the things we're actually building into this workbook is actually a tab for each practitioner type. So if you're in LICDC, you can go click on a tab and you can see all the codes that represent the activities that you do and that can be billed using the codes. LISWs will have one, LIMFTs, LPCCs, unlicensed, RNs, LPNs. We're building one for each practitioner type.
Everyone that's currently on the chart will have a tab.
School psychologists, not to skip over your favorite area there, Cicely. So we're hoping that will provide a certain level of utility, not to tell you what you do, but to help you understand the codes and the rates that are associated with the services that you are rendering and providing. In addition, we're trying to build in benefit information on that so that people say, hey, the benefit limit today is this, what does it look like tomorrow? I'll touch on that in another slide because we're naturally building it. Angie pointed out a little bit of it earlier with the psychological testing slide. So there are some natural things that start building out as the benefit package or benefit administration, if you will, which is very different than the way that we have it today. So we are not actually trying to copy over what exists today for mental health and SUD in terms of benefit limits, but we're cataloging what exists today, and then we're going to work from that moving forward. Just as a side note here, we have some of the services again cataloged where the codes and the rates will remain the same. We have the Specialized Recovery Service Program codes there in the middle. And then down here at the bottom for mental health provider types, which is a provider type 84 in mid-speak, we are going to turn the screening, brief intervention, and referral to treatment codes on. There's 2 of them, one representing a 15-minute service, the other representing a 30-minute service. And there is a limit on those of 1 of each of those services per year, per patient, per agency. So that's the type of thing that we're now building over into benefits. You also can go, we were talking earlier, the pharmacy and labs, the vaccines, office administered medications. So starting to put this together, the next 2 slides are our current catalog, if you will, of coverage and limitations that we can explain today. So for mental health partial hospitalization, the code is H0035, it's a per diem, which means it could be billed 1 time per patient per day. Anybody can only get 1, there's 1 day. We recognize that for children's providers, they are accustomed to being able to bill 2 of those, but to line up with an actual true per diem, we will be implementing this one as 1 per day. Now, we'll take a little side track into SUD and ASAM. When you look at the American Society of Addiction Medicine outpatient levels, which is outpatient, intensive outpatient, and partial, they actually parse that out by number of skilled treatment services per day. So they actually have kind of a built-in benefit limit. For adults, it's less than 9 hours per week, and for adolescents, it's less than 6 hours per week at the outpatient level. Doesn't say what services are in that mix, just refers to skilled treatment services, and it gives you up to less than 9 and less than 6. We then jump into the IOP level of care, and you can see there for adults, it's between 9 and 19.9, and adolescents between 6 and 19.9 per week. So it has a built-in benefit expectation there. And then for the partial level of care, the adults and adolescents are joined together, and that's greater than 20 hours per week. Now, when we talk in this one, similar to what I mentioned about partial up there, we have a shared IOP code, H0015, which represents group counseling. It's not an amalgamation of all the services, it's just representative of group counseling at these levels. Because it's a per diem, it can be billed once per patient per day. It's also used across the IOP and the partial level of care. So there are modifiers that are attached, and there's actually different service expectations in there. And even though it's a shared code, the individual's in one level of care or the other, so it doesn't mix between there. Okay, we talked the psych testing slide. You know, it's mirroring the current Medicaid benefit of 8 hours annually, calendar year.
Many combination.
Any combination of those across the calendar year, but there also is the ability to exceed it through a prior authorization process. I mentioned the SBIRT, the screening, brief intervention, and referral to treatment. We also make note over here that we did not actually activate those for the SUD providers. We are the provider type 95 in mid-speak, if you will, but they will come online for mental health. They also are associated with a number of other MITS provider types. We had discussion yesterday. There was a provider that said, hey, we run a primary care clinic, which is provider type 21 group practice, and we're a 95. Does that mean we can't use it? No, you can't use it under your 95 provider type, but you can use it under the provider 21 because you're doing the screening and the brief intervention in the health arena there. So that providers are starting to look at and understand how that can work dynamically in the system. Here's our discussion earlier about evaluation and management codes for the new and existing. 1 per day per practitioner per patient. There is a soft limit right now that Medicaid uses of a max or a 24 across all provider types that can bill this. So primary care is in this mix with us too.
Per calendar.
They have the ability to do retrospective reviews of this. If they do, they're looking at the patient in the service delivery. As I mentioned, they would look across all provider types that use this coding in relation to that 24.
So to make it clear, it won't deny past 24, but that's when we would start to do a review.
Right, it's 24 per calendar year.
I don't think it's going to deny it.
No, that's when we refer to as a soft limit. It doesn't, the system doesn't cut it off, but there is rule or policy on it that they will look at things potentially in excess of the 24. We could spend a whole day on the SERS side of the house, but I don't think we want to digress there today. Then we have the Specialized Recovery Services Program. In there we have the Individualized Placement Support Supported Employment, IPSSE, and we have the Peer Recovery Support. These are a little different. They don't, with the exception of the peer that actually has written into the state plan that you can't receive more than 4 hours per day. These two services are driven off of a person-centered plan of care, and we'll talk about that in the SRS section a little bit more and provide additional information there. So the driving factor or the authorizing factor or the thing that controls that benefit is that person-centered plan, with that exception of the 4 hours.
We'll switch gears yet again and move into a discussion related to managed care. So hopefully you can start to kind of see how the vision and the work is unfolding in terms of timelines and how the pieces are starting to fit together and how the coding, for example, kind of starts to shore up integrated health care, expanded access. We've talked about expanding the continuum of care and adding some additional services into the mix. And now moving into what is to occur on January of 2018 as we move into managed care. So the goal of this in terms of how we've structured the work and the timing of the work, we did have some rationale behind that because we wanted to make sure when we transitioned into a managed care environment that we had all of these pieces figured out. We had the coding work done, we had the rates established, we had the policies developed, we had the benefit package completed, the coverage and the limitations were clear. So as we move from fee-for-service into managed care, all of that work was done and there could be a seamless transition from that perspective. So hopefully this is starting to make sense to folks in terms of how we have timed all of the work. So with that said, as we started kind of fleshing out kind of all of the work under Redesign about 2 years ago, and more specifically about a year ago for this piece of work that I'm going to be talking about, we had a group of folks get together, our stakeholder group, and lay out some of the key dimensions that we needed to make sure that we had identified and fleshed out in a little bit more detail that we really needed to be paying attention to as we started thinking about the carve-in of the community behavioral health services into managed care. So that's what these next several slides lay out for you. So we wanted to make sure that we had an adequate network of providers. So we needed to make sure that we had access to services and supports at least consistent with what we have envisioned through the BH redesign. And we needed to have clear expectations of that network adequacy, clearly identified for behavioral health services. And another theme as I go through this, and you'll hear me repeatedly mention this, we need to pay particular attention to making sure that we have adequately address the needs of kids because they are oftentimes served across multiple systems. So we wanted to make sure through the transition that we were adequately addressing those needs as well and paying attention to that. We wanted to make sure that we were addressing integration and maximizing the integration of behavioral and physical health care, as well as recovery supports that keep folks stable out in the community. And we wanted to make sure that we were doing this work and had a targeted timeline for carve-in that gave us adequate time to prepare at all levels of the system. So the plans had time to prepare, they were able to adequately build their network, have their systems developed, providers had adequate time, we were able to educate folks, individuals receiving services, they had time to understand what the benefit looked like. So we just wanted to make sure that everything was consistent and lined up and our timeline gave folks enough time to prepare. We've talked a lot about the coding changes and standardizing, so we wanted to make sure that we could standardize where it made sense, all the way from making sure we've thought about IT systems and how data will be shared, how codes are structured and reimbursed, making sure that, for example, if services will require prior authorization, that we've got clear policy associated with that. And then again, making sure that any sort of special needs for kids that are associated with the child welfare system, for example, by way of outcomes, we've standardized those and accommodated that for children. And that kind of leads into the quality indicators, making sure we've paid attention to appropriate quality indicators, not just for the adults we serve, but for the kids as well. And we had a few questions earlier on around revenue cycle management and assuring that claims payment would be consistent with what folks are used to today. And I know that when we transitioned into MITS, folks were very concerned about if that was going to be disruptive to their revenue cycle. And I think folks found that once folks were billing in MITS, that the revenue cycle was improved. So we want to make sure that as we transition then to managed care plans paying for these services, that we've made sure that we've got considerations and we've addressed any sort of revenue cycle issues from that perspective as well. And then also making sure, again, on the kids side, because funding can come from several different systems, that we've made sure that we're clear about how all of those pieces and parts need to fit together. The next slide covers stakeholder involvement and making sure that we have involved consumers and the plans and providers and boards and associations as part of the development of our approach to transitioning into managed care. And again, recognizing there are some nuances depending on the populations and making sure we've got those addressed. Another key area, and these two things are kind of combined in a way, accountability and care management, and making sure that we have clearly defined the roles and responsibilities between the plans and the providers, and making sure that is infinitely clear so that we're not just adding more and more and more, and it gets confusing and to the individual receiving services, and we're all kind of working at different purposes and bumping into each other. We just need to make sure that we've got roles and accountability and responsibilities clearly articulated. Other key components include credentialing and contracting experience, and making sure that folks understand the credentialing processes in a managed care environment. We need to make sure that there is adequate experience in terms of providers that are on those network panels, and making sure that the plans are familiar with the types of services and providers that children may be using, particularly if they have experience across multiple systems. And I've already kind of touched on the care coordination piece, but then in terms of data and outcomes, we need to make sure that we have adequate infrastructure to support the exchange of information, and that in terms of the outcomes that we have established, that they're focused on clinical and consumer outcomes, not just a bunch of processy types of outcomes. So I've touched on some of these as well, making sure that we've got an expanded array of service that's consistent with what we've talked about this morning. We need to make sure we've clearly articulated provider requirements, and at the end of the day, always making sure we're working towards achieving, goals and outcomes that are consistent with what folks receiving services in the system want and need, and that they are benefiting from our design, and making sure that there's consumer satisfaction built into kind of everything that we are doing through this transition. So this is kind of at a high level, all of the key dimensions that as we move forward with this work, and quite frankly, we've been focused on all the work we talked about up to this point. So this is kind of where we stopped in terms of our managed care work for the time being. Took a pause there, did all the other things that we've talked about earlier today, and would envision that over the next few months will be, once we get some of that other work floated and people are moving into the new code set, that we will then be able to shift more of a focus onto the managed care carve-in work that needs to occur. In terms of the overall design of the managed care approach, wanted to share that with folks. We spent some time, I think last May and June, kind of hashing through what would the overall design look like. And we gave folks an opportunity to weigh in. We gave a couple different options, and then gave folks the ability to kind of write in any sort of other option through our surveying process. But we had 3 options for folks to think about or modify in their responses. So the first option that we talked about with folks was just to be able to take our benefit and say, okay, existing plans, this is what we want you to implement. So here you go. Then the second option that we talked with folks about and kind of weighed the pros and cons was, okay, why don't we, would folks be interested in considering a separate behavioral health focused managed care entity to manage the entire behavioral health benefit? And then the third option is what we landed on that is articulated on this slide, is that we will work with the existing managed care plans in the state, but require those plans to delegate certain components of care coordination to those qualified community mental health providers to do some of those care coordination components. So that's the model that we're moving forward with. And we got some questions yesterday about, well, what are those components and what are the qualifications? And that is the work that is yet to be done, but want folks to be aware of the approach that we are taking. So then in thinking about how we move forward with making some of those decisions, we kind of have those grouped into 3 categories for folks to think about. So one, we know across all plans there needs to be standardized approaches in certain areas. So we want to make sure we've standardized across the plan's clinical outcomes and plan performance measures related to behavioral health. We want to make sure that there's consistency in terms of how folks think about high-risk populations. We want to make sure that billing and coding methodologies are standardized, hence all the work we've been doing to date. And we want to make sure there is a consistent benefit design, which you're starting to see unfold. So then there's another bucket, the second bucket, where we want plans to align in principle, but there could be slight nuances or deviations across the plans in terms of how real-time data is shared, how they want to engage in electronic health record connectivity where possible. They may have some different strategies, but everybody moving forward with value-based purchasing. We want folks to align in principle around utilization management, but there could be difference in terms of process, how that might occur in terms of forms or approaches that they might take. And then the third category is where things, purposefully can differ by design. So if plans want to purchase specific expertise in behavioral health, they certainly are able to do that, additional supports, things of that nature. If they want to negotiate very creative payment strategies and incentives with providers, by all means, we would encourage that. And then at some point moving into selective contracting. But we understand that as we make this transition and for continuity of care purposes, we're going to have some of those provisions in place to make sure that through the transition, folks are remaining stable in the care that they're currently receiving. So that, in a nutshell, at a very high level, is kind of the work done to date associated with the carve-in. And again, that is scheduled for January of 2018.
Hi, I'm Sarah Zielinski. I'm standing in for Mary Haller today for Ohio Medicaid, and I'm going to talk about our specialized recovery services, but before we can do that, we need to talk about our disability determination redesign, which is also known as DDR. Here we go. So currently, we are under Section 209B of the Social Security Act and spend down. And within this one program, there are 3 different ways that an individual is able to meet their spend down. So the first one is the reoccurring spend down option. It's kind of the automatic option where the person has established their current amount of monthly costs or unpaid medical bills that will meet that spend down, and then that person is automatically enrolled in Ohio Medicaid. The second option is what is referred to as the pay-in option, where your spend down is considered met as of the first of the month. So even if your actual payment maybe isn't made until later in the month, it's still considered met at the first of the month. And then the third option is what's called the delayed spend down. And so this is where the individual must incur those costs. So that could sometimes be meaning actually payment of money to the physician's office or whomever practitioner they're seeing, or sometimes physicians or practitioners don't actually collect those monies from that individual, but it's considered incurred just because it would have needed to have been spent. So those are those 3 options that are really very different for all individuals in one program. So that kind of seems disjointed and not extremely streamlined. So the state is looking to go to the 1634 option. So 1634 is just another section, thank you, of the Social Security Act. So within 1634, this option will allow the state to accept the Social Security Administration's decision for SSI. And in Ohio, that will be the opportunities for Ohioans with disabilities, known as OOD, will be making those decisions. So that is just one entity that will be making that decision for eligibility for SSI for all Ohioans. The SSI beneficiaries will be automatically enrolled on Ohio Medicaid, and the state will not be doing any sort of reconsideration of the determination. So once they are determined eligible, they will be eligible. As I said before, that there is kind of the fairness issue with the 209B and the MAGI population. So remember I said there are 3 different ways really that someone could incur that spend down to become Medicaid eligible. So under the new 1634, we could have a person who would be under 65. So these are kind of 2 different situations. There's someone under 65 without Medicare, and they can get the MAGI adult coverage with their income of up to 138% of the FPL. Or there's a person who is 65 or older or who has Medicaid, and they would have to spend down to get to that 64% of the FPL. So these 2 individuals with the same spend down amount, so they would have to incur that same monthly spend down, would have a very different result based on what treatments they may need and from what provider. So in one case, we would have the provider maybe never actually attempted to collect the incurred bill. That was one way that I mentioned in the delayed option, where the provider didn't actually collect those monies from the person. Or in the other case, that the person had to pay up front, so they already had to spend those monies to be eligible for their Medicaid and receive their service. So under the new 1634 option, it will be simplified. There will be one way to be determined Medicaid eligible, and there will no longer need to be the spend down or the calculation of that amount of money or the actual collection of those funds. So, for our disability determination redesign, in July of 2016, the Ohio Medicaid will eliminate this program that is going to essentially no longer make individuals spend down the portion of their income to qualify for Ohio Medicaid as a result of streamlining this determination process. It is important to note that this will take place in July of this year, and if an individual has spent down at all, just 1 month in the past 12 months, they will not lose their Medicaid coverage in July. They will be put into a 6-month waiver that we are applying for currently for CMS, which will allow anyone that has been flagged as meeting their spend down at least 1 month in the previous calendar year. They will go into this kind of 6-month extension, you can almost call it. So no one is going to lose their eligibility, their Medicaid coverage, if they have met spend down for at least 1 month in the past year. So that's very important. So don't think that, many people are going to be losing their coverage come July. If you've met your spend down at least once, you're good. And then during that 6-month kind of grace period, there will be the waiver, which will allow people to ensure that their transition to Medicaid will be met. So at that time, after the 6 months, they'll do the determination, the SSI determination, to ensure that someone is either Medicaid eligible or no longer eligible based upon their income. So here's just some more information from the Office of Health Transformation. There is the white paper available, and that kind of gives some more in-depth detail, and it's available on the Health Transformation website.
You say, while people are thinking about that, there's a couple things we probably need to point out a little bit more. That Medicaid has requested a waiver from CMS to do that 6-month grace period. It has not been approved yet, but we're operating under the assumption that it will. And we do need folks to be aware, though, that there still is an at-risk population there. Sarah mentioned you have to meet spend down at least once in the preceding 12 months. There are likely individuals in that group who have not met that. Those would be the folks at risk of dropping off come July. So there's a little bit of breathing space, but there are probably folks in there, and we're trying to help get them identified so that they can go through eligibility redetermination to see if they qualify for another category.
And if they do not meet that eligibility redetermination come January 1 of 2017, it is assumed that they'll be eligible to purchase on the exchange. So that is the option for those individuals. And like Doug had just previously mentioned, those individuals that may be at risk for dropping off but need some enhanced recovery services, which Cicely will tell us about in just a few minutes, those are those people that we really need the help with ensuring everyone is identified so that they can remain Medicaid eligible.
And then just one other thing, we got questions about this in earlier BH 101 forums. In terms of the redetermination, so there'll be that 6-month period. And then folks have asked, well, is everybody going to be redetermined in January? We're going to have this big flood of determinations that need to occur. So it will then occur as folks come up for their redetermination. So the folks then in January that would naturally have had their redeterminations come up in January, then they will be done. Then folks that had their determinations come up in February, that's when theirs will occur. So one of the questions was, well, what if it's somebody that was scheduled for August? So then because they fall within that 6-month period, their redetermination will occur the following
Does that make sense?
So I'm going to spend some time, the rest of the time today, talking about the Specialized Recovery Services Program. So as Sarah was talking about the DDR and the getting rid of spend down, most people who are no longer eligible for traditional Medicaid or have no way will either purchase from the exchange or be on Medicare. Then we knew that there was this select group of people who needed more intense behavioral health services that were going to lose coverage because of this transition and couldn't access those type of services on Medicare or from the exchanges. So we wanted to create a program that would kind of create a catch for those individuals. Okay, so because of that, we've created the 1915I state plan program called the Specialized Recovery Services Program. We're estimating about 4,000 to 6,000 individuals with severe and persistent mental illness who would otherwise lose their Medicaid eligibility are going to be eligible for this program. So this is a state plan program that is in the Home and Community-Based Services Program. So because of that, it must meet the HCBS requirements, which I'll go into more detail because it creates kind of a set of
Additional layer.
additional requirements for this program that would not be there otherwise. So the Specialized Recovery Services Program is 3 services. To be clear, the person who is eligible for this will also have their full Medicaid card retained, but these are 3 additional services that they will receive. That is recovery management, individualized placement and supported employment, and peer recovery support. Because of the HCBS requirement, we had to come up with additional services for these individuals, and these are the 3 that we settled on. The individual is required to have the recovery management services to remain eligible for this program. The other 2 can be provided at the discretion of the person-centered plan if that individual needs these services. There are 5 requirements for eligibility. They have to be in an HCBS, let's see on this one. We have to be an HCBS qualified living situation. They have an ANSA, which is the Adults Needs
Strengths assessment.
Strengths Assessment. And they have to have the SSI determination, have an SPMI diagnosis, and then meet the financial eligibility. So we're going to start first with talking about the recovery management services. So the recovery manager is actually going to be a selective contract with Medicaid. There are 3 different contractors in the state. You can see on the map which regions they cover. We have CareStar, the Council on Aging, and CareSource, not to be confused with the managed care plan. CareSource is a separate entity that they've created to do case management type services. So these are going to be the only people in Ohio who are doing the recovery management service. So you see here, the recovery manager, HCBS requires there to be this idea of conflict-free case management as a requirement. So because of that, the recovery management contractors will have to have essentially 2 separate entities separated by this firewall, if you will, where the recovery manager will do the ANSA, find the diagnosis. They're not diagnosing themselves, but find documentation of an SPMI diagnosis. They'll do the initial person-centered care plan. They'll make get all the documentation, and they'll make a determination on eligibility for the individual who is applying to be in the SRS program. This is then sent over onto the other side of the firewall to this IE, or independent entity, who will validate this eligibility determination. They will review the documentation, they will review the person-centered plan, and they will make a determination of eligibility for these requirements. The final financial eligibility still lies with the CDJFSs, so that will be sent then for final financial eligibility. But that is how an individual becomes eligible for this program. A little bit more about the recovery manager. We have like 4 slides on this, so I'm kind of going to breeze through them. But the recovery manager not only does the eligibility determination, but they support this person-centered planning process. So they're going to work with the individual to perform some care coordination. They're going to work on the person-centered care plan of care, document their desires, needs, goals, perform the ANSA, and they will also be the one recommending the 2I services, which is peer recovery and individualized placement and supported employment. They will not be recommending the other Medicaid services. Let's skip through this. Oh, actually, I'm going to go back really fast. Just to clarify, the recovery managers are going to have a bachelor's degree in social work, counseling, psychology, or a similar field. They have to have a minimum of 3 years experience with people with SPMI. They have to be trained in the ANSA and the person-centered care planning and HCBS living arrangements and in incident reporting. So we're working on training these providers in all the requirements that are needed to fulfill the eligibility requirements and the continued person-centered care plan work. The thing I want to pull out on this slide is as the recovery manager verifies all of their eligibility, we have come up with a HCBS checklist document that you can click and find out to kind of give some guidance on if the patient's living situation is HCBS compliant. The recovery managers will be trained in this, but it's also a helpful tool for providers.
Anybody in here familiar with like DODD waivers? Okay.
Not many.
Yeah. There's a difference when we talk home and community-based services. Our program is coming up post-implementation of a number of federal regulations regarding home and community-based services. Existing HCBS programs such as DODD and I think ODM, aging, they are actually going through a transition period. They have developed a transition plan. It's been submitted to CMS. CMS is reviewing it. I don't think Ohio's has been reviewed yet. And they are working through some of the finer points.
Ohio's
It's approved.
has been submitted, but it is not yet approved.
So in that, they have an opportunity, a different opportunity than we do to deal with home and community-based settings. Because we are coming up after those federal regs went into place, all of our patients, all of our program participants here will have to be residing in an HCBS compliant setting. I think that's the reason we're highlighting this, is you can take that checklist that Medicaid has published. It's not a rule, even though it's out on their clearance site. I think Sherry, you or Fonda or somebody, it's in the packet too. So you have a copy of that. If you think you have somebody who might qualify, the first thing we would probably suggest is make sure you go through that to see if they're in a compliant setting. There's some additional stuff there, but I think more as we do roll out and do training on the program will be shared there. But when to kind of point that out, we have a different thing is that we have to be HCBS compliant from the get-go.
Yeah, no, thank you. So briefly, that's the recovery management code that those 3 contractors will be billing. The next SRS service is the IPSSE, the Individualized Placement and Supported Employment. This is the evidence-based practice for supported employment, and includes things such as benefits planning, job coaching, job development and placement, job seeking skills, on-the-job training and skills development, vocational rehab, and vocational assessment.
So do we have any providers in the room that are actually certified to do supported employment today by the department? The thing we point out here too is there's general employment support, supported employment. This actually is the subset, the evidence-based practice of IPSSE. It's up underneath Dartmouth again. So it's an actual specialized version of supported employment. So it's not just the broad one, it's a very targeted one that's here. Thank
Yeah.
you, Cicely.
No, you're fine. So yes, this has to be certified through Ohio MHAS. And it is billed in 15-minute units. You can see the two codes there, H2023 and H2025. They're the same rate. One is for the initial visit and one is for ongoing. But like we mentioned before, this is actually something the agency has to be certified in to perform.
Provider type 84.
Yes, for provider type 84s. Did you have anything else about certification?
It's not certification, but our footnote there's a couple of things that come along with the HCBS. There are things called structural reviews. Medicaid is another contractor called Public Consulting Group. They do go out and they will be making visits. They're called structural reviews, where they can do things such as checking employment records at agencies. There's also a criminal records exclusion list for employees to be able to bill Medicaid for this service. You need to make sure that anybody you hire for this, that you need to go through and do that whole background check and see where they fall within the exclusions. When we talk about peer in a minute, we need to clarify, because there's a little nuance with exclusion list there. So back to you, Cicely.
All right, so the next service is peer recovery support. This is specifically to the 1915I peer recovery support. We'll get into where it lives, other places in just a second. But so this is exactly how it sounds. Different services that include assisting the individual with assessing and developing support systems, attending care team meetings, developing and working towards individualized personal recovery goals, daily living skills, coordination among providers, and more description of that. Group facilitation that addresses symptoms, supporting individuals in achieving personal independence, and teaching skills to navigate the healthcare delivery system. So this is also a program that is certified by Ohio MHAS. This is actually the individuals and the agency need to be certified in peer recovery support. It is also a 15-minute unit. You can see there's the 80038 and then with the HQ modifier for a group. So like I said, you must, if you want to bill for the 1915I to Medicaid, you have to employ individuals who are certified by Ohio MHAS. The difference that Doug was pointing out just a second ago was that there are two different, for the background checks, there are, what is it called, criminal records checks. There are two different exclusion lists. Mental health has one for their certification standards, and Ohio Medicaid has one for the payment side of things. There are 5 permanent exclusions on Ohio Medicaids that don't live on the certification standard one for Ohio MHAS. So it's important to look at those and compare the differences between the two so that you can bill Medicaid.
Yeah, to Cicely's point, we are working on a guidance communication to be able to, show the differences between those exclusions, and then to make sure that folks understand from a Medicaid perspective that list in relation to certification. So we hope to have that out in the next few weeks, middle of the month perhaps, so that we can get that out to folks so that you can understand kind of those differences between the two programs.
The complexity that comes in, Cicely mentioned the 5 that are considered as permanently excluded under Medicaid, but then underneath that there are a myriad of others that differ in duration of exclusion. I think for the most part, the MHAS professional certification is 3-year as a general periodicity, and Medicaid goes up to 7 on some of those, I think. So you may actually, and we're developing something, but Medicaid a couple of months ago actually developed a table that demonstrates the differences in there, so you may see that floating around because it was passed out to constituents too.
Yeah, that
It'll
will
be
be
an
part of the
appendix.
committee.
It'll be an appendix to the rule, so.
So we're trying to help get the information out so that people can make sound judgments
Informed
about this.
decisions. Yeah.
And that, it's not a blanket preclusion, but there may be some differences in the ability to bill Medicaid or not.
So their peer support does not just sit in this 1959 SRS program. It actually kind of lives in about 3 to 4 different areas. I'm going to start with the mental health side. So mental health has it, you can start with the Specialized Recovery Services Program, which I just went over. It's authorized by the person-centered plan, has a limit of no more than 4 per day, and it's only eligible for those people who are in the SRS program. Alternatively, though, also in the mental health world, it is an ACT. We talked about that earlier, that you can bill for peer under the ACT program. ACT is likely going to be entirely prior authorized, so peer services would be prior authorized within that as well. This is that face-to-face contact with a peer is what qualifies you for that monthly peer billing. If we look back at the ACT billing
Like the breakdown.
setup, there was a line that you could bill for a peer. And so that would be the face-to-face contact with the peer, you would get to bill that ACT peer billing level. On the SUD side, it lives across the spectrum, really. It lives in the SUD outpatient, so that is that 0 to 9 hours of any services per week. It's authorized by the treatment plan. It's a discrete service that you can bill discreetly. It's that 80038 code. It's the same as in the SRS program, but it's used in the SUD side. And it's just the peer recovery supporter is part of the clinical team providing services. It is also in SUD residential. This because it requires a peer recovery supporter on staff, and they are an authorized part of the treatment. It's authorized part of the treatment plan as well. This is available to all residents since they are part of the clinical team, and it's covered as part of the per diem. So, do you have anything else you need to add about?
I think when we've been out talking, there's been a lot of focus on just the SRS program, and we kind of just take this as an opportunity to say we actually are bringing the peer into more than just that program. The caveat I give here with the residential, I mentioned earlier that we've been working through like the staffing models there too. I don't recall seeing anybody taking peer out as a suggestion, but it has a lot to do with the rate modeling there too, when they're in and they're out kind of thing. And it's also a little bit different over there because when we bring it up under the levels of care, they become an integrated practitioner as part of the actual clinical team providing the service over there versus the model in the specialized recovery services of more of the home and community-based level of service provider there. There's a little footnote down here, and Cicely touched on it around ACT and prior authorized. We have it over here in the SUD world that the current state plan construct gives permission to do levels of authorization. We don't have anything tangible and proposed there, but we do try to keep people in mind that there may be some prior authorization in that side of the house too. So that's it.
So quickly, there are the 3 rates for the 3 services. As a sample letter of what we are sending to consumers that we believe will be eligible for the SRS program. We collected the data based on income and diagnoses and mental health services in the past. And we are sending these out very shortly to let them know that they may be eligible for this new program. They will get to keep their Medicaid benefits. They could receive new services. We list their specific recovery management agency that they will need to contact in their area. And we list some basic high-level eligibility criteria for them to start to evaluate We wanted to make these available to you as well, so that people come into your agency with them in their hands, or you have someone who you think may be eligible, that you have information to help them through the process.
Right, and on the individual's letter, it will have the contact information filled in. So on these ones, it just kind of leaves a blank space, but on the individual letters, it will be included.
So really quickly, I'm just going to breeze through this one. If you think you have people who might be eligible, or people come to you with this letter, we ask that you help them contact the Recovery Management Service, or send them to that numbers they can call and get the eligibility process started. Also, this you can sign up for newsletters on the website, but I'll show you that in just a second. Really briefly, wanted to talk about the Specialized Recovery Services Program and the Managed Care coordination. So for MyCare Managed Care, individuals can be enrolled in the SRS program as well as MyCare. MyCare Ohio plans may prior authorize SRS programs because they are responsible for payment for these services. The MyCare Ohio plans are going to contract with the providers in their network. They are not going to perform the recovery management services, however, that still remains with the recovery management contractors.
And the independent entity.
Yes.
Right. Right, so that portion will not change just because someone is duly enrolled in MyCare.
The MyCare, the recovery manager is going to have to be incorporated as a part of the MyCare Ohio's transdisciplinary team for these providers, so they will have to coordinate the care coordination between them. The IE is still going to be performing that eligibility determination for the program. It's a little bit different for the non-MyCare managed care. For these individuals, the managed care plans are not financially responsible for the SRS program because it is carved out still, so they must coordinate with the recovery managers as well, though, but they will not be financially responsible for the care.
Right, and therefore you will be billing Medicaid directly.
And you want me to?
Well, as a kind of as a helper, you see this one thing down here is, because this is a special benefit, it actually is being built in MITS as an actual benefit plan. So when you check eligibility, we're figuring out the finer points of how that's communicated. Either when you log in, you'll see it, or if you do the electronic transactions, how that's returned. And before we left, I didn't want to forget your question, Glenn. When it comes to the person-centered plan of care that we talk about here, that is guided or facilitated, if you will, by the recovery manager. They don't develop it in a vacuum. They would develop it in consultation with the peer recovery services provider or the IPS SE provider. So they're this kind of little team of three, if you will. You know, that is separate and apart from a clinical plan of care that they may have developed and have, if they're over receiving clinical services under their regular Medicaid card. You know, sometimes they may even come together if the agency that's providing services to the individual has the IPS and the peer with it, so it makes sense that to them it probably would look more like an integrated plan, even though it technically is two separate things. But we're trying to be clear that the plan of care here is just in relation to recovery management, IPS, SE, and peer.
You don't have to get, it doesn't have to get approval from the recovery managers to do the other Medicaid programs.
While this is tied to the elimination of spend down and making sure that folks who could potentially be at risk have this program to maintain their eligibility and get access to additional services. And even though we've got that 6-month period where folks will be maintaining their eligibility, this program will be available July 1st, so we want folks to start accessing these services, and we want to get folks eligible through this program. So we definitely, did I say the wrong date?
No, you're good.
Okay. So I just wanted to stress to folks in this room to please share this information. You know, if you are providers, be thinking about how you can go through your caseload, and if you think folks might be eligible, certainly start using the tools that are available. You know, boards, other folks, associations, to the extent that, you know, you can start sharing all of this information and pointing people to the website, we would definitely encourage you to do that.
Yep. So the last thing, this is our contact us slide on the bh.medicaid.ohio.gov. We encourage you to sign up for our newsletters and to get the midsbits. But also, if you have specific questions that you want to submit via this form, as we always say, please don't call the Consumer Family Hotline or the Medicaid Consumer Hotline. Those are for consumers. But we will be putting the frequently asked questions here. If you have questions that you want included on that, please go ahead and submit it. We actually have a communications team that goes through all of the questions that are submitted so we can get them answered.
So, but in that regard too, I believe, Sherry, you and your staff are cataloging the questions here, and we're using those as the foundation for the FAQs. You know, oftentimes people will call any one of us. You are more than welcome to. But we really are encouraging you to submit it through that, because we do go through a very formal process of identifying the question, identifying who's prepared for answering it, and then to the extent it's applicable, it will show up and be posted here. So.
And we actually do it. I just sent back a response yesterday to a question we got on the website. So.
I think with that, we are here and open for any other questions, comments that folks have.